So hi everybody, welcome to IPHA's third Thursday Lunch and Learn web series. We like to dedicate this time every month to sharing some of the successes, some of the detours, or anything else of our work that helps us grow. The point is just to connect, learn, and strengthen the voice for public health in Iowa, which of course is the mission of IPHA. If you're a member of IPHA, we thank you for that. And if you're not yet a member, we invite you to join us to help carry out our mission. You can do that on our website at iowapha.org. Today we're talking to Molly Gosselink and Ashley Ezzio and Debbie Kane from the Iowa Department of Public Health, who will speak with us about the Doula Project for African American and Black families in Iowa. But before we get started, just a couple housekeeping items. Your microphone should be muted during the presentation and camera off, just to help keep some bandwidth and make sure everybody can see and hear the presenters. You can put your questions in the chat or the Q&A features of Zoom, and there will be time at the end for some live Q&A. You can turn your camera on, you can come off mute, whatever you'd like. The session is being recorded and will be posted to the IPHA YouTube channel, where you can find this and any other archived lunch and learns or any other presentations after we're done here. But with that, I'll turn it over to Molly, Ashley, and Debbie to introduce themselves and go ahead and get us started.
Okay, well, this is a list of Debbie, Ashley, and I's names, and we all work at the Iowa Department of Public Health. And as each of us goes through our portion of the slides, we'll just introduce ourselves and let you know a little bit about what we do at IDPH. Okay, so as Brett mentioned, I'm Molly Gosselink. I am a nurse in the Bureau of Family Health. I work primarily in maternal health and family planning and do some work on this doula project as well. Today, we're going to be talking with you about the implementation of this project from an IDPH perspective. Our partners are super important, and the doulas across the state who are doing this work are the key players in this game. So we just really want to hold them up, but you get us today, and we're going to talk to you about how we landed on this project and the nuts and bolts of it and how it's working out and where we plan to go with it. So the map you see is the current 23 maternal health centers across the state of Iowa. Title V and Medicaid maternal health centers are how those agencies are broken up, and they provide nursing and social work services across the state. So we currently, how we decided to land on these counties. Debbie is going to get into that with the data in a few slides, but I want to point out that the 4 counties with the stars are where the project is currently being piloted. It's specifically for African American or Black identifying women who are pregnant and eligible for Title V services in the state. It's a really small project. We had funding for 40-ish people, and we're getting close. So we're kind of looking into year 2 funding to add some more clients. So we'll talk about that closer to the end too, where we're going with that. But one of the reasons we determined the best route to house the doula project within the Title V agencies is that these agencies are a wealth of knowledge for these communities already and would be a good home base, we thought, for the doulas who are working in the counties to help link their clients they're working with back to other community resources. There have been a few bumps along the way. We will talk about those as we go through it, but overall the structure is working pretty well. So that is the setup of the doula project across the state. So we're in those 4 counties currently, and moving on from there, I will also introduce some of our key partners. So as I already mentioned, the doulas doing the work and the Iowa Black Doula Collective, we just really have to hold them up. They are helping us immensely with this. The Iowa Black Doula Collective has been training doulas for the past year with some funding they received. They use DONA training, and Ashley will talk more about that in a little while. We also are so appreciative to our local Title V agencies who agreed to work with us on this pilot project and the bumps we've had along the way. So Polk, Scott, Dubuque, and Black Hawk counties. The University of Iowa, we have a couple of wonderful consultants there who are helping us with a variety of things. Nastasia Pullman is a midwife. She's helping with us with lots of clinical pieces, as well as helping our doulas navigate some of that the educational pieces along the way through the different trimesters. And Dr. Deshauna Jones, she is helping us with evaluation of the project. So helping us determine where we need to pivot for year two, doing lots of qualitative work as well as some quantitative work also. And the Mid-Iowa Health Foundation is one of our funders. And Dr. Nalo Johnson over there has been a great supporter of this work and really helped us get it kicked off when she was an IDPH employee. And then the list on the right-hand side of the screen is the IDPH folks who are working on this project primarily. And we've recently added a new partner at IDPH as well. B. Sanchez is helping us with documentation and billing. So I will now pass it off to Ashley to talk about what a doula is and a little bit about our project.
Thanks, Molly. So before we get started today, I think it's just great to have a definition of what a doula is. I hope everyone on the call is saying, I already know this is repeat, but just to make sure we're all on the same page, a doula is a non-medical professional and they're providing emotional, physical, and informational support to families. So this looks like in the prenatal period, they're providing birth planning. They're talking about options in birth. So before a family ever sets foot into a labor and delivery room, they're preparing them for what to expect and what's to come. They also are encouraging their clients to engage in healthy behaviors, activities, ensuring that they're going to their doctor's appointments, asking questions, really leading them through that process. During the labor, so the actual birth, a doula can come into the home for those early labor symptoms to help with comfort measures, get bags ready, whatever that needs to look like, and then provide support throughout the entire birth process. So there's no shift change, there's no anything like that. That doula is there throughout the duration of the birth process to provide comfort measures, help make decisions, help facilitate good communication between healthcare providers and families. And then that moves into the postpartum period. We are working with birth doulas. There are postpartum doulas. A birth doula is trained specifically in this prenatal and birth period, and they provide immediate postpartum support. So that typically looks like the first few weeks to 6 weeks. There are postpartum doulas that can provide care to families in a more intense method and for longer durations. The doulas involved in this project are birth doulas that are trained, and they are providing breastfeeding education. Through the project, we were able to provide advanced lactation support and training, so they're providing that to their families as well. Can go to the next slide. And one really important thing to differentiate the doulas involved in this project compared to what you may have heard from other doulas, this is a community-based project. It is culturally congruent and community-based. And what that means is not just that the doula lives down the street from the client, but this is really about, these doulas represent the African-American Black community, and they're serving African-American Black families. They belong to that community and understand what it's like to birth in that body and navigate healthcare systems. And that is one of the reasons why this disrupts some of the disparities that we see in maternity care. They also have an understanding of what resources are within the community. A typical private doula would not maybe provide as many intensive supports. They also would not perhaps help a family find housing or get connected to a local WIC clinic. So they're really well engaged in their community and know what supports can be offered to families. We can go to the next slide. This is a little about what we structured the program to look like for doula services. So I kind of already spoke about the prenatal period, birth, and postpartum. Within this prenatal period, we are asking our doulas to do a 30-minute consultation. And that's really so our families can interview with each of the doulas and choose a doula that's right for them. And that is a typical practice that you'll see in private doula practice, but really important to bring to our community-based projects so families have options And then we ask for 3 prenatal visits. Those can be up to an hour. I think most doulas are doing a lot more than this, especially if a family is entering care early on, which is one of our goals, that they're providing that birth planning that we talked about, health education topics, and just facilitating healthy communication. The doulas are there throughout the support and 2 hours after birth. That's really to help with infant feeding methods if breastfeeding is chosen or whatever the client's choices are. Our postpartum support is a little enhanced. And so we asked for 5 visits for up to 6 weeks of support. And that really came from the fact that we were able to provide doulas with advanced breastfeeding training. And so they could be another resource in the community to provide breastfeeding support, troubleshoot questions, make phone calls, have community with. And so that is kind of the structure of what the doulas are providing there. You can go to the next slide there. And I'll turn it back over to Molly.
Actually, this is Debbie. I'm going to pick it up from here.
Hey, Debbie, can we pause really quick before you start? Because Ashley has to jump off at 12:30. I just want to make sure there aren't any questions for Ashley. We still have plenty of time, but just in case we don't get back to Ashley before she has to leave. Anybody have any questions for Ashley? And if anything comes up, we can find her and we can get your questions.
Absolutely. My colleagues can share my email address. I'm always happy to answer questions. And we really do function as a team. So I completely trust that Molly and Debbie can answer your questions as well.
And if we can't, we will, we have no shame. We will get them back to Ashley. All right, Debbie.
All right, I'm always excited to be here to talk about data. Data makes me very happy. I'm a maternal child health epidemiologist, and I'm in the Bureau of Family Health, and I provide data support to a number of different programs. So, you know, as we first started developing this program and thinking about it, we wanted to look at what difference could doulas make and what sort of outcomes are we trying to influence within the state? And now many programs within the health department, including our IMQCC and other projects, are looking at reducing the rate of severe maternal morbidity. And here you see some information about severe maternal morbidity and how there's disparities between white people and people from racial and ethnic groups. And for those of you not familiar with severe maternal morbidity, this indicator is calculated based on 20 conditions such as aneurysm, acute renal failure, cardiac arrest, eclampsia, hysterectomy, ventilation, like I said, a whole collection of different diagnostic codes from the Iowa hospital discharge file that are then consolidated into one single indicator. So you see there are some dramatic disparities in the outcomes, but you also, as you look at the information, you'll see, because the numbers, the events, the actual count is relatively low, we needed to combine data over 3 years of time. And also, when you think about whether or not doula services can necessarily influence the severe maternal morbidity rate, that may not be true. So I'll be talking about some other outcomes that, while at some point, perhaps these services will reduce severe maternal morbidity. It's important for us to monitor this, but there are other outcomes that we can look at specifically with our families, and that for which the data is more accessible. So Molly, if you want to bring it to the next slide, that would be great. So now something that we talked about is that these services are taking place in 4 counties, and these are at Title V agencies that also receive Medicaid reimbursement or can bill Medicaid for services. And we hope in the future that the doulas will be able to do this. So that's one of our goals. But anyway, looking at this, Medicaid reimbursed a higher proportion of births among birthing people who identified themselves, I don't know if you can see my cursor here, among Hispanics, American Indians, and Black, as well as multiple races. So we see that Medicaid is a really important reimbursement source for services during pregnancy and at delivery. Next slide, please. So then we also look at, I think I might have put, this actually should be prenatal care, and I apologize. This is access to prenatal care. And if you think about Healthy People 2030, a goal with prenatal care is to look at the proportion or increase the proportion of pregnant women who receive early and adequate prenatal care. The baseline measure is 76.7, and in this slide, or the target measure is 80.5. Now, if you look at this slide, overall, 78.6 of birthing people with a Medicaid reimbursed birth obtained early and adequate prenatal care. However, you see that really varies by race and ethnicity, particularly low among families who identify as Black as well as Native American. And when we think about something that we can influence with our services in Title V and with the doulas is to support families to get into prenatal care so they get that early prenatal care to identify different health needs and education. So this is one of the goals of the doula project, is to support women and families to get into early prenatal care. And if we share these slides, I'll make sure I correct this slide before we send it on. I guess I had I don't know, something happened to my brain when I was putting this together. So this is supposed to be prenatal care. So next slide, please. Let's see what I name the next slide. If it's anything related to what it's supposed to be. Yay, it's the right information. So you'll look at breastfeeding initiation among those with Medicaid reimbursed births, and you'll see again that there's a lot of variation by race and ethnicity, and the doulas and our Title V programs, we believe, can really influence these rates to help to increase that to the Healthy People 2020 goal, which is in this case 81.9%. So you can see we have a ways to go among all deliveries that are reimbursed by Medicaid, but certainly among our target population for the doula project. And as Ashley presented, that postpartum care and visiting with the new mother to support her in breastfeeding her child can really make a difference, as can support for breastfeeding initiation in the hospital. And the reason we selected these, one is we really feel that doula services can influence these, but another thing is we have this information available on the birth certificate so that we can measure that as a state for a whole, as well as the clients who participate and based on the counties that are participating. So it really is some helpful information. And next slide, Molly. Okay, then also we're looking at birth outcomes, and in this case, looking at low birth weight. Well, in the early initiation of prenatal care can really make a difference in terms of influencing low birth weight, in terms of supporting families in good nutrition. If the birthing person needs to quit smoking, you'll see that the percent of low birth weight is much higher among the Black population. And so not only do we hope to influence initiation into prenatal care and initiation of breastfeeding, but hopefully those activities will also support healthy birth outcomes. So we have lofty goals for our doula project, but I have no doubt with our team and the team of doulas that are working with us that we can make some differences to the families in the 4 counties that are part of this initiative. So Molly, I think it goes back to you onto the next slide.
It does, and you have really set us up nicely to talk about what the goals of this project are. So overall, this is a multifaceted approach to a pretty big topic that's really been at the forefront of the public health world for a few years now: maternal mortality and the rates in Iowa, the rates nationally. Some really great national campaigns have come out. To Hear Her campaign through the CDC. If you're not familiar with that, Google it. They have tons of resources and tons of languages, and it's just wonderful. So that was a little tangent about maternal health in general, and in raising awareness about the need around healthy pregnancies. But our project goals really align with that as well. So decreasing maternal morbidity and mortality through, as Debbie said, some intentional activities like increasing the rates of early and regular prenatal care and increasing what that multidisciplinary support looks like. Ashley is a doula, I'm a nurse. It's been a wonderful adventure and lots of interesting conversations about navigating that birthing space. Who does what in a birthing room? Who's responsible for what? And there are so many conversations. And if you're a doula or a nurse, you've had these conversations about who does what. And we really, a goal of this work is to ensure that the patient or client, they are in charge of that birthing room and the work and the birthing work that they're doing. So there's space for whomever they want as part of their birthing team. Increasing breastfeeding initiation rates. Debbie talked about that, and Ashley did as well with some of that support. Diversification of the perinatal workforce, so not just with racial diversification of the perinatal workforce, but also bringing more doulas into that birthing room. Evidence for consideration of insurer reimbursement for doula services. So Debbie had mentioned that one of our goals is to ask for or to look at doula reimbursement with insurers and Medicaid. So that is something that we are looking forward to starting to work on later this year. And implementation and evaluation. We still have Ashley on. I want to skip over to some training stuff. Ashley, do you mind talking about the training stuff? And then I can talk about implementation and evaluation at any point.
Sounds good. Thanks for making accommodations for me. So we were really lucky in September of this year, we were able to collaborate with the Iowa Black Doula Collective. They had some funding to provide training, DONA training. Their DONA stands for, it is an International Doula Association. There are a couple that you may hear of. DONA is a big one. CAPA is very popular here. ICEA, there's the National Black Doula Association. They're all certifying bodies for doulas. And so when you become a doula, you take a certification course that's about 16 hours in person at least. And then from there, you can call yourself a doula, but you're still certifying. And so you still have requirements to meet. There's a book list that has to be read, typically a test or a paper written, and then they need to do 3 births. And those births they receive feedback on. So not only from their clients, but from a provider. They also have to talk to a healthcare provider and explain their role. And so all that documentation is done. So I give you that background to say we were lucky enough to partner with some really key partners, the Iowa Black Doula Collective, and IDPH was able to fund 7 doulas. Another program was able to fund another 7, and 14 new doulas entered the state in September, which more than doubled the workforce. Prior to this training, there were only 6 Black doulas in Iowa. And so adding those 14 in brought us to a great number. And our partnership with the Iowa Black Doula Collective continues to expand that. They just did a training in April and in June. And looking forward to more in the future, but that's really where that diversification of the workforce is happening. And so we created a training application and a doula program application so that folks that were going through these processes and becoming new doulas could connect with our program. The application collects some basic demographics. It touches on some of those community-based points we talked about earlier, ensuring that folks do understand what community-based work looks like and that fits within their business model. And then really we're taking doula work from what can sometimes be considered more of a spiritual, very loose individual way of practicing, and we're putting it in a state structure. And so this application process allowed us to require some key elements, background checks, mandatory reporter training, liability insurance, completion of a program that we felt the certifying body encompassed some of our values here at the State Health Department. So that application process comes through and we work with the Iowa Black Doula Collective and certified doulas to provide mentorship for people coming in. I encourage you to go to the Iowa Black Doulas Collective's website and really look into what they're doing, because they do wonderful stuff. They are not only helping train doulas, but then they really take them under their wing, at least for the first year, and do trainings on how do you run a business? How do you set up an LLC? What do you need to know about liability? As well as if you're at your first birth and you're hitting hiccups, you have someone to text, someone to rely on. And so we've integrated some of those concepts into our mentorship process to ensure doulas aren't out there feeling unsupported. We don't want burnout. And so we're really hoping that this support creates long-term doulas that will continue to serve families for years to come. We were also able to do the certified lactation consultant or specialist training through our WIC program that provided funding. And so that's where that advanced breastfeeding training comes in. So once again, just equip doulas with the training and mentorship they need to serve clients. I don't know if you want me to pass it back to you, Molly. Molly and I kind of tackle this one together. A lot of folks will ask us, a lot of folks will ask us, how do you pay for doula services? And that's a great question. Private doulas here in Iowa run anywhere from $800 to $1,500. And those supports that they're providing are much less than what we've outlined in this project. So if that is not doable, families rely on grant funding, and grant funding, as we all know, can be a lot less than what folks should be reimbursed at. And also just creates some scarcity, and there's some qualifications that go with it. I think that is why it is so important that we are putting this project together to gather data, to learn more, so that we can really advocate for payer reimbursement. We do see this happening in 4 or 5 states nationally, and we're following those states. We're talking to them. We're brainstorming about what's happening. Oregon is a great example. Their reimbursement rate was as low as $350, and that is not a livable wage for a doula. That barely covers transportation to meet with clients. They are submitting a state amendment to increase that to $1,500. So we're really excited that we're seeing other states recognizing that there is a fair wage for the services provided. If you're interested, you can click on the National Health Law Program. We are included in the work we're doing, but you can see nationally all the programs that are happening for doula services.
All right. Ashley, is there anything else you want to add before you take off for the rest of your day? As we have all mentioned, we do lots of different things here at the health department, not just this. So.
Yes, I want to thank you all for your time. I'm sorry I have to leave early, and I did not introduce myself. I'm just realizing that at the end of this, but I do work at the Iowa Department of Public Health. I'm a community health consultant on the breast and cervical cancer programs. If you've seen my name there, hi. I also help out with the doula project here and kind of am a liaison between doulas and the community and the project. Happy to answer questions. Thanks again for your time.
Thanks so much, Ashley. And Ashley does way more than help out. That's an understatement right there. So, right, I'm going to go back a couple of slides, just mostly to prompt myself to make sure I don't forget anything. So, again, we are sharing our perspective. There's a whole other perspective out there with the doulas in the community. So, and I can send that to IPHA too. Anytime we're having other presentations and they are involved in them, we'll definitely send them your way. They're great to listen to and have they can bring other perspectives. We're only talking about our project today, so lots of different ways this work happens across the state. So as Ashley mentioned, we are taking a doula service, which looks different for every single doula out there. There are some guidelines and scope of practice that some of those certifying bodies have, but in order to make the case for provider reimbursement of these services, we had to create some structure around it, which is we have gathered tons of input along the way. We continue to gather input, like with the evaluation process, and Dr. Deshauna Jones is picking up all of those comments for us, and we'll make some changes. But to lay everything out, we developed an implementation guide that it's a living document. We are updating it all the time. I think every couple months I'm sending a new version of it out, and it guides the practice. Ashley adapted the DONA Code of Ethics to meet our needs. So we have made sure that our educational elements are supported by the American Academy of Pediatrics, ACOG, A1, so that when a client is being served by a doula who is working within this particular program, they're hearing the same message about safe sleep or breastfeeding or infant feeding, maternal health support education. They're hearing that same thing from the nurse they might be working with, the social worker they might be working with, and the doula. That was really important for us, as well as and all of our agencies too. So the Title V agencies and the doulas work together to do both the intake and the discharge of the client. So the clients have the choice to work with the nurses and social workers and the doula. They can work just with the doulas if they want to. They will have to meet with a nurse or social worker or someone doing intake and discharge at the beginning and end of their services, just because of how we've set the program up, which several clients have picked to do both programs, which is awesome. It's a time commitment on their end, and we totally appreciate it and love that we get to give them support in a variety of different ways. So we talked about the evaluation or the implementation guide. We've talked about how the agencies work together. Data collection to evaluate the program. So what is Dr. Deshauna Jones doing? She is doing, we're surveying the clients before but when they start the services and when they end the services to see where their education is, how that's changing, and where it'll help us focus some of our educational aspects for year 2 and year 3, and how to build this program and add to those guidance documents we have for the doulas. Our implementation guide also gets into the liability insurance piece of it, which is something I never thought I'd be talking about with people from across the state, liability insurance of doulas. And so all of that is outlined there, as well as how HIPAA and doulas go together and all of that. So that is in there as well. And I think I've hit on all these topics now. I want to pause for a second and answer questions before we get too much further. We've been doing a lot of talking, and I know this is supposed to be more casual, so. And the slides, I did see the slide. Oh yeah, good, Brett set that out about the slides. Feel free to unmute yourself and show your face if you want to ask a question. I'd love to see it. All right, I'm going to move on. Don't be afraid to speak up if you have a question.
There's a
Molly, there's a-
question.
Yeah.
Oh, there's a question.
Yeah, for those not using Medicaid, are they uninsured or insured by other plans?
Okay, that's a great question. So for this particular project, they have to be financially eligible to get Title V services, and that's unrelated to whether they're eligible for Medicaid. So if they are below 375% of the federal poverty level, they're eligible. While they're pregnant, they're eligible to participate in this project, even if they have third-party insurance as well. So that's how we determined who is eligible for this. Also, something we've talked a bit about, but not expressly, is that this project is specifically for African-American families and pregnant women. So they are, because it's all culturally congruent care. All of our doulas working in the project are also African-American or Black identifying. So a couple of qualifications there about the project, and we we hope to expand to other areas someday, but working with these first 40 clients has helped us develop some processes and figure out where we need to make some changes along the way. So it's good that we started small. All right, let me figure out how to advance some more slides. All right, Ashley talked about the doula and breastfeeding training already. Talked about doula payments. Yeah, everybody, the states that do reimburse, do it in their 5 states that reimburse. It just happened, so we haven't updated that, but 5 states that reimburse, and they all do it differently, and they all pay the doulas differently. Okay, so doula in Title V, some common goals between the 2 projects. It's been so nice to see the complements of each program with each other. Increasing access to prenatal care and increasing breastfeeding rates. Those are great common goals. Decreasing postpartum depression. The doulas have been meeting with these clients throughout the beginning of their pregnancy, and they were there for the birth. They're able to have an awareness of the mood changes in their clients. And they're also, those Title V agencies are there for the doulas if they happen to have any mental health concerns. We are keeping track of needed referrals for mental health too. IDPH in our strategic plan last summer for maternal health identified mental health care needs as one of the top priorities. So we're keeping close tabs on needs around that and where we can do work around that. Opportunities to educate the community on doula work. That there's outreach built into this project, and in all of the communities, the pilot communities, the doulas and the Title V agencies are out there building up the information on doula workforce, what a doula does, and also talking about the importance of early entry into prenatal care. And developing those relationships with providers and community members, that is something we've been really digging into the past few months. Those nurses and physicians and hospital systems, and where and how doulas fit into it, and what's IDPH's role, and all of those topics have really been adventures we've been going on. And that kind of gets into some of these successes and challenges. Definitely, and Ashley and the doulas can really speak more to the element of distrust. So historical practices in the medical field and historical trauma, and trusting the systems of medical care. And we have been working on that through bringing the data to light. What does it really look like? What do the data really show? Debbie just talked all about that the disparities exist, and it's important to focus the work where with the people who are experiencing those disparities in a way that they want to be helped. So lack of understanding of the doula profession has been one of my favorite conversations, because often Ashley already explained to this group what a doula is, but we've come into it from lots of different perspectives. I've had people ask me if doulas only deliver babies at home, and doulas don't deliver babies. They support women who are delivering babies, but doulas will support you at home or in the hospital, wherever they are the clients choosing to have their baby. We've already talked about that rigid state structure. The doulas are all independent businesses, so they're all subcontracted through the Title V agencies to work within kind of the guidance of the IDPH implementation guide. Mentorship needs have varied, and we've tried to navigate that. Some doulas have been in this practice a long time. Many are just delving into the doula work, so they need more support. And sorry, for some reason, my slide there at the bottom is cut off. Individual opportunities for growth as well as standard. Can you guys see what it says? Sorry. No? All right.
It is cut off for some reason.
Okay. Well, I'm not sure 100% what that says down at the bottom, so I can't tell you more about that. All right. We can certainly come back to challenges and successes. I just want to tell you a little bit about where our plans are going in year 2, because we are officially, we started seeing clients, the project did in January of this year. We had some planning time. We were planning to start actually serving clients last fall, but as with anything related to a pilot, we had different barriers to overcome to getting those subcontracts in place and getting all of the different elements needed to start services. So this is what the work looks like right now. Almost all the counties are full. So we've moved a little bit of funding around, and they all should still be serving clients through the summer. We are hoping, because our funding starts over again in October. Clients are filling out the pre and post care surveys. We've already talked about that. And we talked about the Black Doula Collective and all of their trainings. This summer, the doulas, we are hoping to provide a trauma-informed breastfeeding support education. So how to approach supporting the practice of breastfeeding in a way that is trauma-informed. And funding and reimbursement. We've secured the PHHS block grant funding for year 2, so that's starting this fall, and working to secure some other grant sources to support the work as well. The Iowa Department of Public Health was awarded the Erase Maternal Mortality Grant fall of 2021, and we are approved to get that. I believe in some of this work will be included in that work plan for this coming year as well. So that's really exciting, because Erase Maternal Mortality is specifically focused on the health disparities that are the outcomes of maternal mortality reports, and the doula work the importance of it and the support is shown all over the data. So community building, we are working on what our meeting structures look like. When Ashley and I are meeting with people and trying to uninvolve ourselves at a state level, we really want this work to be done at the community level. As Ashley said, the workforce was really small at first. It's growing really quickly, which is so exciting. And Ashley and I are trying to be there, providing technical assistance when needed, but this work will be at its best if it's those doulas and the agencies who are working at the community level with the clients doing the work, and us standing on the sidelines and supporting and cheering them on the whole way. We're building up some more of that community support this summer by hoping to organize some hospital tours and meet and greets in the different areas, because some of the doulas are serving in areas they don't live in. So Dubuque and Scott County over on that side of the state. And those relationship building pieces that we've already talked about a little bit. All right, year 2, we are hoping to serve 70 clients next year. So with the increased workforce and the funding, we believe that will be possible. We're working on the feasibility of Iowa Medicaid reimbursement with Iowa Medicaid, and that work will start later this fall. Continuing to evaluate the work and outcomes of the project itself. IDPH and our evaluator at the University of Iowa are planning to develop a year-end report that will come out late November, early December of this year, depending on when all of the data can be compiled. And I'm sure, as many of you know, IDPH has some rules around releasing low numbers, so we will release whatever we can. But our numbers are small with this project. So continue to educate and build the workforce in collaboration with the Iowa Black Doula Collective, and Ashley already talked about that. And those are all the slides we have. I feel like we've just dumped lots of information on all of you, and maybe you have some questions about it.
If there are any questions, now's a great time to come off of mute, turn your camera on, or just keep throwing questions in the chat, whatever works.
Hey, Debbie, one of my favorite topics to talk about is a question
Yes.
that
Which question? What was that?
the question is curious about how much we know about uninsured moms in Iowa. I don't know what data you know off the top of your head.
I guess I hate to quote things off the top of my head, but we can look at census data. The 2021 census data will be available after July 1st, 2022. So we use that information, as Molly presented earlier in the in this presentation, about our community. What do you call it? CSAs. I forgot what it means.
Oh, collaborative service areas.
Collaborative service areas, yeah. We did look at uninsured rates among both men and women, and we can look at women of reproductive age. So I think it really varies by county, but in all honesty, we have pretty good coverage for insurance. And looking at the birth certificate, there aren't that many people that list themselves as uninsured, and Medicaid has a program, it's called emergency coverage, so that if a family for whatever reason is low income and does not qualify for Medicaid, that delivery can be paid for by what's called emergency coverage, and it gives the mom coverage for the delivery and the time that she spends in the hospital post-delivery. So that is available. That's not to say some people don't qualify that and are uninsured, but in general, our Medicaid is called generous. If you probably remember Molly saying that it covers up to 375% or 375% of the federal poverty level. So we really do reach a lot of families with our Medicaid, so that families are not uninsured at the time of delivery, and a low income family in that situation, the infant would be eligible for Medicaid. So that's one way we do really get most families covered, at least for the delivery. And there's also a process called presumptive eligibility, during which the determination is being made for the family to qualify for Medicaid, and the family or the pregnant woman can begin to get services like lab work and some prenatal care during that time of presumptive eligibility. And with that, some prenatal or some clinics will say, you know what, it's more important for us to stay connected with this family than to not provide a service, so that we don't have women coming in to deliver where we have no information. So I think that some prenatal care providers make allowances so that they know who's coming into the delivery room, so they're not surprised by a high risk delivery. So that's what I would say with regard to that. And that's not saying that there aren't people that are uninsured, but I think there's many programs that are available to support coverage for the delivery and prenatal care. Just another thing I would add to that, our Title V agencies also really can be considered a provider of last resort and can help connect families to services. So, you know, a goal really is for the family to be connected with some service to support the healthy pregnancy, and then also healthy and safe delivery of that newborn. It's probably men, if you're worried about who's uninsured. I think the group that, I know we're talking about MCH Day, but a group that sometimes just is not insured, or say families without children, adults without children that don't have chronic illnesses, or men. So that's a topic for another conversation. But I think as far as birthing families, Iowa does a really good job of providing services. So it's a long answer, but.
Thanks, Debbie. Great info. I love hearing you talk about that. I'm throwing a couple of links in the chat to the Iowa Black Doula Collective. They are a wealth of information and providing some really amazing services across the state, and we are forever grateful to them for their work. And I'm also going to put in the link to the Iowa, or the National Health Law Center they are all, I know often there's a lot of MPH students on this call, and it's a great resource for you to have.
Molly, I see a question in the chat saying, going beyond the data, do we have testimonials or success stories? And I think Deshauna Jones actually will be, in her evaluation, will not only be looking at quantitative data, but also qualitative data, because we know that, you know, as much as I love data, I recognize that it's, there's some limitations, I hate to admit it, but they are there. So, and Molly, you can probably speak more to this. We will be, or Dr. Deshauna Jones will be getting qualitative information. And Molly, I think you're closer to that than me.
Yeah, so Lauren, we are collecting success stories, and we actually are working on that right now. And they'll be released with the November report, as well as our outcomes data and kind of a little, the challenges and successes along the way. We, as public health folks, in getting to work in a pilot, feel like it's really important to share those things, to have other people learn from them. Ashley and I've had a really awesome opportunity with this work too. We already have states reaching out to us saying, how are you doing this? What are you doing? And we are reaching out to other states like California and Alaska and Oregon saying, how did you do this? What are you doing? And they ask for advice. And I always say, start simple and and give yourself some planning time, because we had anticipated starting serving clients in September of last year. That was a lofty goal that we had some roadblocks to hitting, but everything really worked out well. And starting in January, those were a frustrating few months though. And looking back on them, I just have to embrace that we learned a lot during those few months, and now we can help others who are starting a pilot project to, if your grant money will allow it, build in a couple of planning months for yourself, or planning year. If you can get a planning year.
I think, Molly, you underestimate all the surprises that came up in this process that could not have been anticipated. And I think, you know, you and Ashley really had to do a lot of pinch hitting and just really a lot of troubleshooting, problem solving, just legal things that you think, did not know that was an issue. So it was a learning experience for everybody.
It was. Hindsight's 2020. It's great to know that now, but yep, start small and simplify any processes you can. All right, I put my email address on that last slide. It's just molly.gosselink@idph.iowa.gov. And I'm happy to get questions to Ashley or Debbie as well.
All right, well, if there's any last minute questions, go ahead and ask them. Otherwise, I think we can wrap up and move on. Well, thank you, Molly. Thanks, Debbie. Thanks, Ashley, even though she's gone, for sharing your expertise with us today. Thanks to all of you who shared your lunchtime with us. This was our last lunch and learn of the 2021-22 season. So we'll be off for July and August, and then we'll start again in September to kick off the fall 2022 season. We look forward to any potential topics that you might share with us. We welcome your ideas to showcase yours or others' work. We're still building the schedule for the next season. So if you're interested, contact me at brett@iowapha.org. We can plan that out. But with that, thank you. And we hope to see you all again in the fall.
Thanks, Brett.
Thank you.
Have a good day, everybody.